morning, everyone. I would like to begin by acknowledging that Concordia University is located on unceded Indigenous lands. The Gahaga Nation is recognized as the custodians of the lands and waters on which we gather today. Montreal is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. I'd now like to present the Perform Scientific Director, Habib Ben Ali.
Good morning, everyone. My name is Habib Ben Ali, and I'm the Scientific Director of the Perform Center. I am pleased to welcome you to the 8th Annual Perform Center Research Conference. Before we begin, I would like to introduce the Interim Vice President of Research and Graduate Study, Concordia University, to open the conference, Dr. Paula Wood Adams. The floor is yours.
Thank you so much, Habib. It's a real pleasure to be here to welcome you all to this 8th annual conference of the Perform Center. I wish we were all together in person, and I'm sure that the next one, the next conference, will be able to do that. I can see from the schedule that you have put together an outstanding, multidisciplinary and innovative program. I'm also thrilled to see that this year, in addition to inviting 2 prominent researchers to give the keynote presentations, Perform's Scientific Engagement and Advisory Committee opted to showcase the exemplary work of Perform researcher members. It's really great to see so many people working together at the center. I was also really happy to see that the new Perform Student Action Committee are holding a skills building workshop designed to provide the students with knowledge and skills to successfully navigate the funding application process on several levels. We really appreciate the work of the student committee in this and many other areas. It's events like this conference that build our capacity to innovate in fields that will have tremendous impact on health research and also society as a whole. Events that serve as a foundation to train highly qualified personnel, to disseminate knowledge, and to provide opportunities for our students to not only acquire knowledge, but also to share their research and foster and engage in open dialogue and exchange to further investigate, to further innovate in their chosen disciplines. This year's conference is an important one in my opinion, because it showcases our history of high impact research and training in many areas of health research. Knowledge translation and training activities such as this conference are key to develop the new approaches in health research and education, especially as we are now on the cusp of starting the activities of the new School of Health, which will offer an exciting new era for Concordia, but also for Perform, which makes, of course, the foundation of our research in health. So finally, in closing, I would like to thank Habib Ben Ali, all of the team at the Perform Center, and the members of the Scientific Engagement and Advisory Committee for putting together this fantastic program. And I hope you all have a great conference. Thank you. Habib, back to you.
Thank you very much, Paula. So this has been an exceptional year for the Perform Center and our researcher members. So we have continued to focus on our research on areas of expertise that are vast and varied in discipline, ranging from exercise science to engineering and computer science, mathematics and statistics to psychology, chemistry, biochemistry, physics, and biology. So the multidisciplinary nature of the research and the synergies that has been created among researchers, platforms, and research discipline has built the foundation for enhanced research capacity across the board. I am pleased to report that since we opened our doors, we have been some 200 research projects take place in our platforms, while we continue to advance research in preventive health. Our shift in approach with respect to research development and our focus from preventive health to health has enabled us to develop outstanding relationship this past years, which has led to the launch of 6 innovative interdisciplinary research projects, bringing together some 22 researchers from varied disciplines. This will have a tremendous implication for training of highly qualified personnel in exciting new ways. In closing, I would like to acknowledge the generous support of Concordia University, partners, organization, and the hard work of the Perform Center's scientific engagement and advisory committee and dedicated staff in making this conference a reality. None of this could have happened without them. I would like to thank all our invited speakers for accepting our invitation to present their work. With that, before I turn the stage over to our first 2 presenters, Dr. Fortin and Dover, I would like to take this opportunity to walk you through a short virtual tour of the Perform Center.
Concordia University's Perform Center is an 86,000 square foot facility that uniquely combines research, education, and community programming all under one roof. Perform accommodates large groups of participants with whom researchers can investigate links between exercise, nutrition, physical activity, and sleep. The goal? To understand how the choices we make on a daily basis affect our long-term health. Our ground level features the conditioning floor, which is open to the public. What looks like an ordinary gym is in fact a space dedicated to well-being through research and community programming. Staffed by Concordia exercise science students and certified exercise physiologists, specialized equipment ties into software that allows researchers to gather large amounts of important health-related data. And it's all happening just a few feet away from our research platforms where scientists collaborate on a variety of studies. In the Functional Assessment Suite, researchers advance the fields of biomechanics, ergonomics, and cognition sciences to better understand how to keep the body moving. But when the body isn't working as it should, Perform's Athletic Therapy Clinic delivers prompt, professional care. Open to the public, the clinic is run by athletic therapy student interns who gain invaluable hands-on experience under the supervision of registered athletic therapists. Perform's Nutrition Suite aims to understand the impact that diet and nutrition have on chronic diseases and overall well-being. Highly controlled meals are prepared in the metabolic kitchen, while cooking classes led by a registered dietitian are held in the teaching kitchen next door. Perform's Sleep Lab helps researchers design studies on common sleep issues like insomnia and sleep deprivation, ones often associated with the onset of both mental and physical diseases. The Cardiopulmonary Suite is used for research into lung and heart health, vital in preventing and managing conditions including asthma, heart disease, and chronic pulmonary diseases. Staffed by highly trained, certified exercise physiologists, this suite can accommodate many research participants and can be modified to meet the requirements of specific research projects. Research teams use the Clinical Analysis Suite to conduct in-house analysis of biospecimens such as blood, urine, and biopsies. Perform boasts a highly sophisticated imaging suite, giving researchers and students an unprecedented opportunity to evaluate and validate lifestyle interventions using non-invasive imaging techniques. Perform fosters transdisciplinary collaborations while shaping future generations of researchers, all under one roof. Concordia University's Perform Center help us advance knowledge in preventative health research.
So now, Dr. Fortin and Dr. Dover, the floor is yours.
Thank you. I'm just gonna share my screen for a second. All right, so good morning, everyone. Thank you so much for the invitation. It's a pleasure to be here this morning. So I will start this talk and Dr. Dover will do the second part. So the idea is to present some projects that were done at Perform, and the overall title is to improve patient outcomes from intervention to the clinical settings. So I will present a project that was done at Perform. It was a randomized control trial looking at the effect of 2 different exercise interventions. So this project was actually funded by a multidisciplinary grant from Perform as well as the EFRQS. And it's showcasing, a project that was actually using 3 different platforms at Perform. So I really took advantage of the unique nature of the facility at Perform to design a complex project where we used the conditioning floor, the imaging suite, as well as the functional clinical assessment suite. So we wanted to look at the effect of 2 different exercise intervention on paraspinal muscle morphology and function in people that have chronic low back pain. So this was a randomized control trial. So low back pain is not a secret for anyone. Unfortunately, it's a major public health concern. It has a big economic and healthcare burden right now. And unfortunately, the pandemic didn't help. People were working from home a lot, were not in a good setting, not moving as much. So it kind of contributed to the problem even more. In terms of statistics, there's 85% of the population that will have low back pain at least once in their lifetime. And the issue is there's very high recurrence rate, and a big proportion of people actually go on and develop chronic low back pain, which is pain that persists for more than 3 months. The paraspinal musculature is something that I've been looking at for the past 10 years, a little bit more. I started looking at this in my PhD, and it's a very hot topic right now. Before, researchers in low back pain were looking at the disc a lot and the vertebra, but there is a shift now looking at the paraspinal musculature because they play a very important role in stability of the spine, and they were kind of left on the side for a while. But researchers started to look at it and investigate what the muscle looks like using imaging. So there's a growing interest and a large body of evidence right now really looking at different features that we can quantify using imaging. And we see strong association between what the muscle looks like with low back pain, different neurocompressive conditions such as spinal stenosis or cervical myelopathy, where there's compression on the spinal cord. And we also see association between what the muscle looks like, so the morphology, and the level of disability of a patient, as well as their physical function. So, we use MRI. It's the gold standard to look at muscle morphology, so what the muscle looks like, to investigate different morphology parameters. So you can see here, this is the multifidus muscle. It's a very important muscle for spine stability, and one of the primary muscle I was investigating in this study. So this is what the muscle looks like in a healthy subject. You can see like dark muscle fibers, but as people develop chronic condition, we can see an increase in fat filtration that looks like this. So you can see the white part here is literally fat that develop within the muscle, and it can really become very severe. So we use these different modalities, including MRI, to quantify these parameters. So the parameters of primary interest are the size, so size, fat infiltration, and also side-to-side asymmetry. primarily in people that have unilateral pain, we want to quantify the difference between sides. So in people with chronic low back pain, we see atrophy, increased fat infiltration, increased asymmetry when we compare them to healthy controls. And we also see deficits in functionality of the muscle. So as you can imagine, if your muscle is smaller, if there's more fat infiltration, it also affects the function of the muscle, so decreased strength, delayed contraction, or sometimes we also see hyperactivity of the muscle with spasm-like. So chronic low back pain is a complex problem. A lot of intervention focused, of course, on pain and disability. Now we want to see how paraspinal muscle degeneration comes also into play. But it's definitely a multifaceted problem, and it also affects different domains of your life, including reduced performance at work, anxiety, depression, fear of movement. People also have pain catastrophizing. They have fear of movement, so they don't move as much. So they have also deconditioning. They're not very active, which can also lead to sleep disturbance. So how all of that interact, and if psychological factors mediate how people may react to different type of intervention is not clear. So there's definitely a lot more work to be done there. And it's also not clear whether after different kind of intervention, if we can reverse some of the spinal muscle degenerative change that we see, and if these change, the amount of change that we see actually correlates with the improvement in pain and disability. So we need to really clarify this a little bit more if we're gonna really push people to work these muscles and try to improve them. So this is the study protocol that was published in BMC musculoskeletal disorders. So the goal of the randomized control trial was really to compare a targeted intervention where we looked at motor control. I will define motor control exercise a little bit later. So the first group did a motor control combined with isolated lumbar strengthening exercise, which was a very targeted lumbar muscle strengthening focused intervention versus a general exercise intervention where there was no focus on strengthening the lumbar musculature, but it was more like an exercise program where people were trying to increase their general fitness and strength, focusing on lower body, hips, glutes muscle, upper body muscle that are also weak generally in people that have chronic low back pain. So the aim of this study, the first primary aim was to compare the effect of both intervention on multifidus morphology and function. The secondary aim was to look at other muscles, so the overall effect of both intervention on paraspinal muscle health, morphology, function, strength, and to see if the change that we see in muscle is also associated with the change in pain and disability. And the last aim was to explore if psychological factors can actually modify the response to the exercise intervention. So this is how the study happened. So we randomized 50 participants that were selected from the local community, and also there's a few participants that were selected from the Low Back Pain Consortium, which you guys are going to hear a little bit later after our talk. So we randomized 25 participants into each group, and they each got 24 supervised one-on-one sessions at the Perform Center. They were coming in 2 times a week for a period of 12 weeks. And we did follow-up assessment at 6 weeks, 12 weeks, and 24 weeks for the questionnaires. In terms of criteria, all participants had chronic low back pain, so more than 3 months, with or without leg pain. They were aged between 18 and 65, speak English or French. They had to currently seeking care for low back pain. Importantly, they all scored moderate or severe on the modified ancestry disability questionnaire. So we wanted to make sure that all participants had a level of disability, and they were not engaging in any sports or fitness training specifically for the lower back 3 months before they started this trial. So in terms of the group, so the general strengthening group, so this intervention took place in the conditioning floor. Participants were doing a 2-day split training program. As I mentioned before, that was focused on lower body, upper body. It was mostly done on machine-based exercise, and the repetition were increased over time. and also the weight was increased over time. So when they were able to do this amount of repetition, we increased the weight by 5%. So they started their session with a warm-up on either a treadmill or a bike for 10 minutes. They did their strengthening exercise and they finished with a cool down, including some stretching exercise. For the motor control and isolated lumbar extension exercise group, so motor control is a type of therapy that's commonly used right now in clinics because people that have chronic low back pain often don't fire their trunk muscle very well. So the multifidus and the transverse abdominis muscle are muscles that are supposed to co-contract together. And often in people that have chronic low back pain, for lack of better word, they're kind of sleeping, they're not firing properly. So in this intervention, the therapist actually has to palpate to try to retrain that contraction. So we ask the participants to voluntarily contract that muscle, and we're looking for equal contraction between sides, different levels, and also making sure that they're not moving their pelvis or they're not firing other global muscle like other abdominal muscle when they're doing those contractions. So the first phase is to really try to retrain that. Participant needs to be able to do 10 repetition and hold that contraction for 5 to 10 seconds. And then they will progress to phase 2, where we add arms and legs to increase the level of difficulty, and we're putting them in more functional type position. And they still need to make that contraction when they were doing those exercises. The second component of that intervention was the isolated lumbar exercise. So this was done on the MEDEX lumbar extension machine. So this is a specialized machine that we have at Perform. You are not going to find that in everyday training gym. So the specificity of this machine is that it has a pelvic restriction. So usually in machines that you can do lumbar extension in gyms, you don't have that system. And the glutes and hamstring muscles are getting activated when you do the extension. But in this specific machine, everybody is fit in perfectly, your pelvis is stabilized, and it really isolates your lumbar extension. So it's an isolated specific training. So participants were doing, every time they were coming to Perform, they were doing 2 sets of 15 to 20 repetition at 55% of their one max repetition, which was of course determined before, and the weight was increased by 5% once they were able to do 15 to 20 reps. Both groups also use the MEDEX machine to look at muscle strength. So this machine is plugged into a computer, so we can do both training, but we also do isokinetic testing on it. So we measure muscle strength at 6 different range so through the 72 degrees of extension, and we can plot their strength and see if there was change over time. And again, we looked at baseline 6 weeks and 12 weeks. So this was done in both groups to assess muscle strength. In terms of primary outcomes, so as you know, we wanted to look at paraspinal muscles. So we use ideal fat water MR images that were acquired at Perform to look at muscle size and composition. So this is a fat water sequence, it's a specialized sequence, and it's the contemporary standard right now to look at muscle composition. So we trace the muscle manually to get the size, and we get a signal intensity for each sequence that we plug into a ratio to get a fat fraction, so a percentage fat within the muscle. So this again was done at baseline 6 weeks and 12 weeks in both groups. And something important is we used a multiple MRI slice analysis at each level. So we looked at 3 different MRI slides per level to get an overall effect. It's more analysis, but it gives a better idea of really what kind of change we may see than just looking at 1 slice per level. In terms of muscle function, so we looked at the multifidus thickness change when we do a contraction. So sorry about that. We had the participants do a contraction at rest in a prone position, as you can see here, and then we ask them to do a contralateral arm lift, and you can see the increase in contraction. So we're doing a ratio of rest to contracted to see what's the percentage change in a contracted state. This was done again at baseline 6 weeks and 12 weeks. In terms of secondary outcomes, so we looked at, as I mentioned earlier in the talk, we wanted to see pain and function, yes, but other psychological factors that are important. So we looked at pain catastrophizing, kinesiophobia, anxiety, depression, and insomnia. And these were all self-reported questionnaires that were done at the same time point, as well as 24 weeks, because we wanted to try to assess the long-term effect of each intervention. So in terms of preliminary results, as you can imagine, there's a lot of analysis involved here. We haven't done everything yet, but I will present some preliminary results today. We did one-way ANOVA repeated ANOVA to look at the effect of the intervention in the motor control group on their musculature. And we did the two-way repeated ANOVA to look at the secondary outcomes, so the psychological factors, so if there was improvement in both groups. So these are the preliminary results for the motor control group only. So you can see now this is for the multifidus cross-sectional area. We looked at the sides separately to really see if the effect was consistent between side. So and two level so far. So L4, L5, and L5S1, which are the two lower lumbar level, the most commonly affected with pathology, and the one where we see the most fat infiltration and atrophy as well. So we can see we saw a significant increase from baseline to 6 weeks at L4. Same thing on the right side. We also saw a significant increase at L1 and L5S1 on the left side and the right side. Those are also changes that are above the minimal clinical detectable change, so suggesting that there's a very true effect happening here. Same thing with the erector spinae. We saw a significant increase on the left side. The results were not significant on the right side at the L5S1, but at the L5S1 level, we saw a significant increase on the left side as well as the right side. In terms of fat fraction, so composition of the muscle on for the multifidus muscle on the L4, L5 level, there was no change. And we did see a slight increase in fat infiltration at L5S1 on the right side. However, in the erector spinae muscle, there was no change at L4, L5, but we did saw a significant decrease at the L5S1 level on the left side and the right side. In terms of thickness, so those were the thickness measures that were done with the ultrasound. So these are the thickness measure at rest. So the muscle in a resting state, prone. So similar to the cross-sectional area, we did a significant increase on both sides at L4 and L5. But if we did the percentage thickness change on this side, though, we didn't see any significant change. So perhaps the increase in thickness were proportional with the functionality. So it didn't change. The thickness change, which we use as a measure of contraction, didn't increase. Now, the last results I'm going to show you today. So these were the analysis where we looked at change in the different psychological outcomes between groups. So you have the general exercise strengthening group with the motor control. We didn't see any significant change between groups, and there was also no group time interaction, as you can see here. And those are the p-value for the between group difference. But we saw a significant within group difference. So in both groups, so there was significant decrease in pain in both groups, significant decrease in ODI, which is a measure of disability, a decrease in SF12, which assesses overall health, so an improvement. Only the motor control saw a decrease in pain catastrophizing scale, and we saw also a decrease in kinesiophobia in both groups. There was no change in insomnia, anxiety, or depression scores in either groups, but their scores at baseline were pretty low compared to other studies that we've seen. And we also found a significant correlation between the baseline pain catastrophizing score with ODI and pain. So people that had a higher pain catastrophizing at baseline also had higher ODI and pain scores. So in terms of discussion and how we can pull everything together so far, we have promising preliminary findings that our motor control exercise intervention did lead to significant improvement in morphology at both levels. From the few studies that did quantify the effect on the paraspinal musculature following an exercise intervention, there's a previous study by Berry et al. That was published in 2019 where they found no significant change in multifidus or erector spinae after a similar program on the medics. They only looked at the L4 level, they only quantified one slide, and they only did the medics intervention. There was no motor control component. So it's possible that the motor control, in addition to the lumbar strengthening, may have led to those significant improvement. There's another study by Wesh et al., another one, like I said, of the few one that looked at the effect of an exercise program. They did find this one of the only study that reported a decrease in fat infiltration at L4, L3, L4, and L5S1, nothing at L5S1 following a resistance exercise training program. One issue though is they didn't separate the multifidus from the erector spinae, so we don't know if it's only one muscle really that changed. And they didn't use the fat water sequence. So they're really the best sequence, the best technology that we have now is the fat water. So this study is the first to really use this sequence and to look at muscles separately at different levels, also using multiple slice analysis, so we can look at more than one slice per level. We still need to investigate the effect in the general strengthening group. We have to look at muscle strength as well, which we have not looked yet. We want to quantify the other level as well. And, you know, the goal was definitely to look at the association, the potential association that we may see between the change in paraspinal muscle morphology that we saw with the concomitant improvement in pain and functional status. So do we see an association there? And also, do we see an association between the psychological factors and the improvement in paraspinal muscle health? So this still needs to be investigated, but bone intervention adds similar effect to reduce pain, disability, and psychological factors in chronic low back pain. This is in accordance with, you know, few studies that were able to show that exercise alone can improve both physical and psychological factors in chronic low back pain. But we still need to look further at whether psychological factor may mediate improvement in paraspinal muscle, which we're going to look at. And we're also going to investigate further whether pain catastrophizing mediate the effect on the treatment outcome that we have. So I'd like to thank all my collaborators and as well as my student, Megan, Alexa, Neda, and Brent, that have done a tremendous amount of work on this.
Okay, great. Well, thanks very much, Dr. Fortin. It was a really great presentation. I'm going to be presenting the second half of our work here at Perform. So, okay, so this is the second part of our talk is going to be a project that we completed in the Perform AT clinic. You might have caught a bit of that in the video before, seeing the students in there and how it's a student-run clinic. So we're going to be talking about that today. So the title of the presentation is The Improvement of Patient Outcomes in a Student Athletic Therapy Clinic. And just like Dr. Fortin mentioned, this work couldn't have been done without the help of my grad students and honors students, Frederique and Catherine. Megan was one of my honor students and was one of my master's students as well. And so they were instrumental in getting this work done, which we were able to complete these projects right before COVID hit. Okay, so we can't talk about the athletic therapy clinic without talking about athletic therapy first. So in case you're not familiar, athletic therapy are health professionals that specialize in the prevention, assessment, and rehabilitation of injuries. We focus on or specialize in the active individual, which can be anything from an office worker who runs on the weekend or works in or someone that, you know, is a marathon runner. So the athletic therapists work in a field and clinic setting. What I always say is that whenever you watch a hockey game and someone gets hurt and people run out and take care of them, those are athletic therapists most of the time. And so that's the field work, working with the team, but they can also be in a clinical setting. In terms of athletic therapy in Canada and athletic training in the US, that's what they call athletic therapy for the NATA in the US. Most of them work in a clinical setting. So these clinical type projects are really applied and relevant to a lot of the athletic therapists and clinicians that work in a clinical setting. And in case you're not familiar, we have an athletic therapy program here in health kinesiology and applied physiology. And it's our internship students that work over in the Perform AT clinic. Oops. So in terms a little bit more about athletic therapy education, just to give everyone an idea of where we're coming from here. Every athletic training program in the US and athletic therapy program in Canada requires students to fulfill an academic and practical competencies. Competencies are sort of learning outcomes or skills that they have to be taught over the course of their education. They're taught these competencies in class and in lab, where we do the hands-on evaluation of it, and then also at internships. Internships are a critical part of the learning process, where the students get some hands-on experience with actual people in order to develop their skills more. Learning these competencies and practicing them in these different situations are critical and are required in order for them to sit for the certification exam. Once they've completed their education, then they can sit for a certification exam and become a certified athletic therapist. There's studies that have shown that this internship, the closer you can get it to a real world situation, the better it translates to the learning. You know, they call it contextual learning, where students are placed in a patient care situation in a setting similar to that of the future profession, which sounds like it would be, you know, a no-brainer, but it's a really important thing to talk about, because it's hard to simulate that scenario without, you know, an actual injured person there, which is going to could be a potentially tricky place in order for a student to apply treatment to, you know, an actual injured person. So that brings us to what a student-run clinic is. You might have heard that in the video before. It's a little bit of a misnomer, because it makes it sound like students are managing or running the clinic, you know, from a budget perspective or something, but that's not really what it is. What references say, what has been cited in the literature, is that a student-run clinic is a healthcare delivery program where students are primarily responsible for the treatment and the operation of, you know, dealing with on a day-to-day basis with the patients. So that's really what their role is. That is what a student-run clinic, when a student is, you know, responsible for the treatment. And this has primarily been done in medical school. So residents having a clinic where you can see, you know, you would see a resident as opposed to a doctor is more common. People are more familiar with that. And so, but it is apparent, you know, or let's say they do exist in other healthcare professions as well. Now, in terms of measuring the efficacy of a student-run clinic, there's not a lot of research out there for that, probably because they're trying to, you know, protect the students. You know, they are students at the end of the day, and they, you know, don't necessarily want to be compared to a licensed professional. But there are a few studies that have looked at the efficacy of a student-run clinic in terms of their treatment or their dealing with the patients. So this one study that came out in 2015 showed that medical students effectively screen for depression, can determine the appropriate diagnosis, and implement universal depression management program. And those are med students, again, at a clinic in the US in California. What's more common with student-run clinics is people will complete a patient satisfaction questionnaire. So, you know, did you, you know, appreciate the treatment? Did you like the treatment today? As opposed to how effective was it at, you know, reducing your pain or function or something. So those are more common, and they have those. There's an example there with an osteopath clinic in Australia. So in terms of athletic therapy, we're switching gears here. So patient-reported outcomes aren't used enough. And so what that is an evaluation of how injured the person actually is. A lot of healthcare professions use patient outcomes for a myriad of things. In athletic therapy, we tend not to use them as much, and that's a problem in Canada as well as the US. Now, in our field settings that we talked about before, with a student or an athletic therapist working with a football or hockey team, that's not a huge concern, because the goal is to return them to practice or competition. So when they do that, it doesn't really matter what they score on an outcome. But in the clinic settings, it's really important, and we don't use them enough, which is something that something we should really do in athletic therapy and athletic training. Part of the reason why we should do it is because, you know, as I mentioned before in the education, we use a skill-based assessment to evaluate the students. You know, can they do this stretch? Can they do this special test? And then that's how they're evaluated. But really, what is our goal is to graduate athletic therapy students who become athletic therapists who are good, who can actually get someone better, right? They're will be successful at rehabbing a person or an athlete. And that's something we don't actually measure. We don't measure as part of our education. We don't measure if the patient or the athlete they're treating are getting better. And so that's really was where this started in terms of this idea we wanted to do at the Perform Clinic, because we think it's a great clinic, and we wanted to see, you know, how much people were getting better by getting treated by athletic therapy students. So that really is what our purpose was for this first study, was to evaluate the improvement in function of patients suffering from a musculoskeletal injury upon receiving rehabilitation or receiving treatment at a student-run athletic therapy clinic that we did at Perform. So as I mentioned before, this is one of two studies we're going to be talking about today. This one just came out this year in the Journal of Athletic Training in this just a short while ago. And as I mentioned before, that was Frederick Berger-Lebel, who was one of my master's students. Okay, so in case you didn't gather everything you needed to know from the video, the Perform Athletic Therapy Clinic is a student-run clinic. It's our internship students complete the treatment in there. In general, we have two types of internship students. We have students who are completing their first internship or their second internship, depending where they are in their education. We used to refer to them by the number of hours they would complete, but we've really switched more to a competency-based learning system, so we don't really pay attention to the hours as much. The students are in charge of all aspects of the patient management, including taking a history, performing the physical assessment, determining the key impairments, designing an appropriate treatment plan, and then implementing that treatment plan. The key thing in terms of the supervision, so we would have certified athletic therapists that work at Perform that meet with the student prior to their appointment with the patient and overview each assessment and each treatment plan in advance. And the certified has to sign off on that. And then that way, when the patient comes in, the supervisor sometimes doesn't even interact with the patient. It's just the student that, you know, greets them at the waiting room, brings them in for their treatment, and then, you know, goes from there. And these are people, injured people from the community primarily. Some are from Concordia, but mostly they're from the surrounding community. Okay, in terms of patient outcomes, Clinic Master was one of the software that they use to collect all the demographic data for every patient that's seen at the clinic. But the main part are the self-reported outcomes, right? These are functional questionnaires that are going to give us an idea how injured someone is when they first come to Perform, and then how much they're going to improve. So there's 3 patient outcomes we used for this study. And they were each patient completed just one of them, depending on which body part was injured. So the first one might sound familiar. That's also the one that Dr. Fortin used in the previous study. Is the Oswestry Disability Index is a measure of disability for someone suffering from a low back injury. Then if someone had a lower extremity, like a hip, a knee, or an ankle injury, they would fill out the lower extremity functional scale. And then that would give us an idea of how injured they are for that injury. And then if they had an upper extremity injury, we would use the disability of the arm, shoulder, and hand questionnaire for that. And all these scales are valid and reliable and have been used in multiple populations and been cited many times. So they're good measures of how injured someone is for various injuries. Just to give you an example, if you're not familiar with them, here's an example from the lower extremity functional scale. So there's 20 questions total on there. One of them is, do you have any trouble, you know, putting on your shoes and socks? How hard is it? Then you have to score it from extremely difficult to no difficult at all. And the total score is out of 80. So one point I'll mention now is that some scales, the higher number means more injured, and there's some scales, the higher number means more functional, right? So this is a case where a higher number meant more functional. So we made all the scales, we reversed some of them and put it all out of a percent out of 100. So for the purpose of this study, 100 meant fully functional and a lower number meant you were injured. So, which is different than what Dr. Fortin showed before. Okay, so in terms of the protocol, a patient would make an initial appointment at the clinic. They would have that case conference between the supervisor and student to approve the plan for the patient. And then the patient would arrive for the first appointment and they'd be approached by the research assistant, which would tell them about the study and then get the informed consent at that point if they're willing to participate. And then they would have the patient fill out the questionnaire based on what injured site they were coming to be seen for. Then the patient would then continue to receive the first assessment appointment with the student. They would receive multiple treatments over time. And then we completed the follow-up, whatever scale they completed the first time, they would complete again approximately 6 weeks later. So some of our inclusion exclusion criteria, we measured men and women. It had to be a new injury. Sometimes people came back for repetitive injuries, but we only used new injuries in this case. They had to be 18 years or older, English or French, because we had both versions of all questionnaires were in English and French. And they had to have either a lower extremity, upper extremity, or a lumbar musculoskeletal injury. We couldn't use them, they couldn't participate in the study if they were under 18, if they couldn't read English or French, if they were seeking treatment for other disorders, including alcohol or substance abuse problems, or if they had any cervical or thoracic injuries, because we didn't have questionnaires to measure that. Some of our descriptive data we collected was the age, gender, acute or chronic injury. So the definition of a chronic injury is if they've had pain for more than 3 months. We also collected if they were seen by a student completing their first or second internship. We monitored the number of treatments between baseline and follow-up at 6 weeks, and then the average amount of days that occurred at that time. Okay, so here's just an overall, look at what one person would look like. Okay, so we've got one person coming in. This will be a new person or a returning person with a new injury. They complete the consent forms. They have the evaluation with the student. They get their treatments, and then at 6 weeks, we measure their outcome at the end of that point. So here's a sample of just one person came in as a 39-year-old with a lumbar spine and acute injury. So therefore, because it was lumbar spine, they completed the Oswestry Disability Index, which out of 100 meaning more functional, they were at a 74%, which represented moderate disability. They were seen by a student therapist completing their first internship. They received 5 treatments over 50 days. And then at the end of 6 weeks, their Oswestry score was a 92%, which meant there was an improvement in disability. So this is just an example of one person going through the protocol, just so you get an idea. Here's our consort diagram. The main thing to take away from here, we had 358 people originally come. This took about over the course of a year. We could use about 167 of them for various reasons. The injured areas weren't part of our study. We had a lot of people complete the initial assessment, 191, but we only had about 59 actually complete the follow-up, which is a serious dropout rate. Now, what I will say is that compared to other clinics, in the community, this amount of dropout is common because once people start getting better, they don't always come to the last appointments. They'll cancel more. And so this type of, having trouble following up on the day they officially discharged is normal, but it's a significant amount of dropout. Okay, so here's our some of our demographic data of the people who completed the study. So we had 59 people complete that initial assessment and the follow-up 6 weeks later. It was almost half males and females. Most people came in for a lower extremity injury. It's about half the injuries for that, and then some for the low back and some for the upper extremity. We had about half our people coming in for a chronic pain or chronic injury, and half were for an acute injury, roughly. Now, there wasn't this many students there, but it's because people see multiple patients. But out of all the visits who completed the follow-up, 44 of them were seen by a student completing their first internship, and 15 were seen by a student completing their second internship. And on average, people received 4.7 treatments over a period of time, about 48 days. Okay, so here is some of our main results here. And so there's a lot of stuff on this table, so let me walk you through it a bit. Okay, so the main thing we wanted to look at was our overall, were patients getting better? So here you can see, this is a score out of 100, a lower score indicating being more injured. So on average, people experienced a significant improvement in function after receiving treatment at the clinic. So that was really great to see. Let's see, what else we got here? Okay, so this is a breakdown of the improvement by injured site. Okay, so this is the first number is the change or the improvement seen in people with the low back injury. This is the improvement seen with people with the lower extremity injury, and the amount of improvement seen with the upper extremity injury. What was interesting about that is that each one of these scales have a minimal clinically important difference, meaning that, if there's a certain amount on the scale, is that enough to be considered a clinically significant improvement in function? Statistically, there was a significant improvement, but was there a clinical improvement in function? And all three of these scores were bigger than the minimally clinically important difference, meaning that all people not only statistically experienced a significant improvement, but it was a clinically meaningful improvement in function, which was really good to see. There was no difference between receiving treatment from a student with their first internship compared to the second. Now, again, the sample size was really different between the groups here, because it was 44 to 15 or so. But it was just nice to see that there was no significant change and improvement from students getting their first internship compared to their second. And then this was the result that was really another interesting result, was that people with acute injuries experienced a significant improvement, and the people with a chronic injury experienced a significant less improvement in their function. And so this is not surprising, considering chronic pain is more of a challenge and harder to get people better. But it was something we didn't really know until we completed this study, how much people were improving and, compared to the acute and the chronic pain. So that was something that was interesting to us, that the acute pain, how much better people with acute injury were improving their function compared to those with chronic pain. So our overall findings there, the overall function significantly improved. People got better after receiving treatment at the clinic. The minimal clinically important difference was achieved for each of the scale, which is really good. And the level of students, I just said, didn't impact the amount of improvement. So in conclusion, the student ATs at the Perform AT clinic were able to get people better, which was great. This is potentially could be used in other programs. This type of clinic only exists at about 2 other places in Canada. So we're hoping that this shows, some evidence that this is a good model to use. And the measuring outcomes are important. We wouldn't have found that out about the acute and chronic pain part unless we were measuring the outcomes. So that was really good. And this chronic pain is a challenge, and we need to do some follow-up on that. Okay, so that was our first study. Let me check the time. All right, we're good on time. So I'm going to quickly go over just a summary of our second study, which was really a follow-up to the first one. So now that we found that the chronic pain, some of those people weren't getting as better as the acute pain individuals, it was something we wanted to measure more. As Dr. Fortin mentioned, chronic pain is a serious, chronic low back pain is a serious problem, not only in Canada and the world. Chronic pain in general is a real burden to society. Recent task force indicated that 1 in 5 people in Canada suffer from chronic pain, which is approximately 8 million people. And as we saw in the previous study, it comprised of about half of the patients seen at the Perform AT clinic are suffering from chronic pain. So due to time, I'm not going to explain all the things that can factor in or can cause chronic pain. We're just going to give one example here. Something that we're interested in our lab is the psychological factors that have been associated with why some people feel more pain than others. So here's a good example. It's called the fear avoidance model. This was originally developed to explain why some people develop chronic pain and some do not. The way to think about this is that when someone gets injured, you know, some people rehab and they get better and they don't have a problem. And there's other people that get injured, they experience pain and they don't get better. And then those are the ones that are stuck with chronic pain. And so this model is originally developed to explain why those people are suffering from chronic pain. So here's an example of what it looks like. You know, someone would experience an injury, they would have a painful experience, and then some people don't have a lot of fear associated with it and can recover with just regular treatment. Other people have a more negative psychological impact from their injury. They have pain catastrophizing, which is a negative orientation towards their pain. This can be fear of pain or a specific pain anxiety, which then can lead to more disability or depression. And then they get stuck in this cycle where, you know, these are the people that have experienced chronic pain. You know, they've had it for a long time. They've seen multiple clinicians and they're not getting better. And this is really that group that we're concerned with. So pain catastrophizing is the one part of the model that we've decided to use for this study. It's a negative orientation towards pain. There's a few subscales of it, which is pain exaggeration, helplessness, or rumification. And so these biopsychosocial model aspects, like the catastrophizing and kinesiophobia, are becoming more standard in other healthcare professions. So for example, in the US, the kinesiophobia and catastrophizing are considered the standard guidelines for people with chronic low back pain, meaning that, you know, it's expected to get an assessment of those if you're coming in to see you know, if you have low back pain and coming in to receive treatment. So it's something that's more common in PTs, but it's something we wanted to explore more in athletic therapy. So therefore, the purpose of this study was to measure the influence of catastrophizing on the assessment, rehabilitation in patients receiving treatment at the student athletic therapy clinic. This was completed by two of my honors students, Megan and Catherine, and which again just came out in print this year. So in terms of the methods, I'm not really going to go over them because it's similar to the previous study. The patients would come in, complete the patient reported outcome, and then we would follow up roughly 6 weeks later. For this part of this study, we were able to add one. We included a neck disability index so that we could have upper extremity, lower extremity, low back, and neck injuries now. People would monitor if they had acute or chronic pain. And then if someone suffered from chronic pain, then they also completed the catastrophizing, pain catastrophizing scale. So I mentioned that. So the pain catastrophizing scale has got 13 statements. There's a 5-point Likert scale. You know, the one thing I'll mention here is that you know, there's some of the questions, or there's an example here. My pain is terrible and I think it's never going to get any better. That's something I talk to the students a lot about, because this is some, you know, wouldn't you want to know this for someone coming into the clinic, right? So someone's coming in the clinic, we assume they're coming in for treatment, they want to get better, but sometimes they indicate on the scale that my pain is terrible and I think it's not going to get better. And I always look at that as, you know, they're planning on not getting better, right? That's, if they score high on that, that's really what it tells me. And wouldn't you want to know that, right? Like, doesn't that seem like a barrier to your treatment if someone is coming in already thinking about this? So really important scale. I'm really glad we used for this study. Here's the other consort diagram. The take-home message from this was, again, it was really hard to do the follow-up. And so we ended up with 49 people where we're able to follow up from baseline to 6 weeks after. And then here you can see the breakdown. We had approximately 29 that came in for suffering from chronic pain and 18 for an acute injury. And then out of this, we were able to do just a small preliminary analysis on the subscale. So meaning that people who scored equal to or greater than 16 on the pain catastrophizing scale, they were put in a high catastrophizing group, and people with low catastrophizing under 16 were put in this group, just as another preliminary analysis. Okay, so here's our results. So the main thing, again, overall, everyone got better. Now the magnitude was a little bit different, similar to our previous study. The people with acute pain improved more compared to the people with chronic pain. So that was similar to what we saw before. And this was an interesting finding here. So this is the subset of people that came in with chronic pain and who were able to complete the 6 weeks. Those that had a lower pain catastrophizing had a higher score of function at baseline and a higher score of function at 6 weeks compared to the high catastrophizing group. Those that came in with chronic pain and had high catastrophizing had a significantly lower functional score, meaning they were more injured or less functional at baseline, and they were less functional at 6 weeks. So what's interesting to note here is that that number, the 72.1, is lower than what most people came in at, right? So that means that at the end of their 6 weeks, they're barely at the level of what someone would arrive at the clinic for treatment. So that was a really low number there. So in terms of our main takeaway, it's similar to the previous study. The patient outcomes improved after receiving treatment. And again, this sounds, some people might have a reaction, people are going to the clinic and they're getting better, and that's sort of a no-brainer, but this has never been shown before. There's over 300 accredited athletic training programs in the States, and there's 9 accredited athletic therapy programs in Canada. And showing that internship students can get people better has never been done before. So that's why it's significant. We're really happy to get our first results published in the Journal of Athletic Training, because that's the official journal of the NATA in the States, even though this study was conducted in Canada. So that was a real significant finding from here. The participants with high pain catastrophizing experienced lower levels of function. This was also noted by Dr. Fortin in their study with people coming in with low back pain, and we noticed the same thing. And these psychological variables, are a barrier to rehabilitation, and it's something that should be screened for. And another reason why we should use patient outcomes, so that we can identify the people that need it, so that we can address those barriers. So this is another thing that comes up sometimes when I talk to clinicians. They get this feeling that, I'm the pain catastrophizing guy. Like, I'm the one that wants to use the scale for everyone. And that's not really the case. As we showed in the model, like, some people are going to get better no matter what, but there's a subset of people that won't. And it's that subset that we need to address the psychosocial barriers. Otherwise, they're not going to get better. And so that's different than saying we need to do this for everyone. It's really identifying the people who are struggling with that part of the rehab and addressing that, which is an important thing. So in the finish here, so we've got time for questions. The Perform AT Clinic is a great model, and it's a great thing to share these results for many reasons. It's a great opportunity for the students. The students get hands-on experience with an actual injured person, and they feel that this is an excellent internship opportunity and a learning opportunity for them. It's the best example of the contextual education that you can find, because it's putting them in a scenario with an actual injured person, which is what they're going to be doing when they leave here. Having this Perform AT Clinic is fantastic for the community. It's a cost-effective treatment option for many people that live in the community to be able to come in, and the health insurance covers athletic therapy up to 80% for most people. you know, and it's the real benefit to them. And something that we've noted anecdotally, we haven't measured anything directly, but people really appreciate the 1 hour appointment time. There are few things in our healthcare profession, you know, like in Canada, where you get a 1 hour appointment with anyone, doctor, PT, psychologist, an uninterrupted 1 hour appointment where someone's dedicated in getting you better. And so the patient, you know, the most patients really appreciate the attention they get at the clinic. And the biopsychosocial model is something that we're going to need to address more in our athletic therapy education because of the number of people that our students are going to be seeing with this in the clinic. So just as to conclude there, we'd want to thank also the funding sources as well as the Perform Center administration. Our supervising athletic therapists over at the clinic, Vicky, Leanne, and Serge are fantastic. And as well as all the student therapists that were treating people at that time. Okay, so at this point, I think we can turn it over to questions. Wendy, were you going to read the questions out to us?
I was. We don't have any at the moment. I think I might have forgotten to mention to our attendees, if you do have any questions for any of our speakers, then please add them or type them in using the Q&A feature at the bottom of your screen. So we'll give just a couple of minutes for people to enter their questions. All right, so we have one question. It's from Habib Benali. He said, excellent presentation. He'd like to know, it's a question directed to Dr. Fortin. He would like to know, in your study, what would be in the future the physiological mediators to be analyzed, for example, by spectroscopic MR, and which would link the psychological factors to the physical exercise?
Yeah, thanks, Dr. Benani. So with the sample size that we have, we may not be able to do like really thorough mediation analysis, but we're going to start by looking at the association between the change that we see in the different muscle parameters. So especially the fat and increase in muscle size with the psychological factors. So it's going to be the pain catastrophizing, the fear of movement, kinesiophobia, and the ones that were shown to have a significant improvement, to see if people had more change in their musculature actually led to having better change in their psychological factors. So we're going to start like this, but eventually this is a beginning study, and we're going to need larger sample size to have more thorough mediation analysis.
Thank you. So we have a question here for Dr. Dover. What are some ways to address these psychological barriers in people with high catastrophizing?
Yep, perfect. Thanks, Steph. Good to hear from you. It was that's one of our next projects that we have planned. Is once we've identified people that suffer from high catastrophizing or kinesiophobia, what can we do as athletic therapists to reduce it in order to facilitate function? So there's some early preliminary results and studies in the States with PTs where they call psychologically informed practice, and which is cognitive behavioral based principles that PTs can use during their regular treatment in order to reduce the catastrophizing or kinesiophobia, while also doing the stretching and strengthening as part of their regular treatment of PTs in the clinic. And so I'm collaborating with some people at Duke University to try and modify that psychologically informed practice for athletic therapists. And we're hoping to have someone do that in the fall. So we'll see how that goes. Oh, Wendy, I think you're muted there.
Yes, sorry. We have another general question from Simon Bacon. So what are going to be the key next steps for the clinic? Is it expansion of the services, refinement of the services, further demonstration of efficacy, etc.?
Yeah, no, there's a lot of things we've got planned for the clinic. So part of it is the expansion of services. So we have a grad student coming in that's going to be starting the TOP project in the fall. So this will be treatment for people receiving gender affirming surgery. And we're going to have a specific program for them at the clinic. So we'd like to start that in the fall. As I mentioned before, we'd like to try a grad student with a psychologically informed practice in order to treat people who suffer from high catastrophizing high kinesiophobia in the clinic as well. And it's also going to be, that's something I need to talk to Deborah about in terms of our expansion. In the past, they've already had to, there's not enough beds in the clinic to be seen, and they've used some of the rooms around it. So it's something that we're interested in expanding as well.
Okay, so we have another question from Dr. Dumont. Thanks, Dr. Dover. This is important work for AT education. What future work or research will convince clinical supervisors and education programs to include students in a similar clinic or giving them access for authentic experience?
Yep, no, that's where the publications were so important in order to get that out, especially the one in the Journal of Athletic Training. We're hoping that by sharing the results and that people can see the benefit that can come from this, we're hoping that more people will be on board with that. And, I can't really control what other supervisors or clinics are going to do. We can just try to provide the best treatment possible at the one that we're involved with. So that's really what my focus is right now.
Great. Another question, professionally, is there much difference between physiotherapy and athletic therapy?
That's a question we get often. There's a lot of similarities between athletic therapy and physiotherapy. We're trained in the assessment rehabilitation of injuries. There's a lot of similarity in terms of the rehab or the modality use. Some of the main differences are athletic therapists are also trained in emergency procedures. So if you're on the field and someone breaks their neck and we have to spine board them, we're trained in that areas where PTs are not. But PTs are trained in higher order brain disorder functions that we're not. So things like stroke and Parkinson's rehab is not part of our program in terms of athletic therapy, but it is for PTs. So those are the main differences there.
Excellent. So here we have a question from Richard. Great, exciting presentations, Drs. Fortin and Dr. Dover. For Dr. Dover, are there types of conditions or injuries that are more difficult to treat for students in the clinic, or at least that have required more supervisor input?
Yeah, that was something that we thought about early on, because in terms of our education with the undergraduate students, they don't complete their spine and pelvis course till later in the education, so they could do an internship prior to that. And a lot of injuries they might see are spine and low back related. However, according to the first study, it really, regardless of the three areas that they were injured in, everyone experienced, well, the average improvement was the minimally clinically important difference. So it doesn't seem like there's any one injury that's lagging behind. According to the data, the lower extremity injuries improve the most, but that also might be because those have a really big impact on just walking around and activities of daily life, so have the biggest range to improve. But right now, it doesn't seem like there's any one injury that's harder compared to the others.
Thank you. So we have one more question. I think this will be our last, so we can move on with the program. But we have a question from Megan. You mentioned that there were 1 or 2 other clinics in Canada that have student-run clinics. Would you consider running a larger study to include these other clinics to be able to generalize these findings outside of the Perform clinic and to provide better evidence for other AT programs to include this type of clinic in education?
Yeah, absolutely. There's one of the clinics is at Sheridan College, and the other one is similar, is at Mount Royal. And I think there might be, although there's PTs that work at that clinic as well, then there's one at Camosun, I believe. So no, I'd really like to do a multi-unit, multi-area study to show the improvement over a larger area. One of the things that would come up is again, and this comes back to why I think these studies aren't done very often, is they're very protective of the student. They don't want to show that a student can't get someone better, or a student they're not getting someone better compared to another institution. So I wouldn't want it to come across as competition between the places. And so we'd have to do it in a way that everyone felt comfortable and everyone, understood that it was just sort of measuring overall improvement. But, that would also be a confounding variable, I guess, would be the different programs that they're in, or the different stages between the programs might be tough.
Wonderful. So that concludes our Q&A session. So I'm now going to pass it over to Dr. Fortin, who will introduce our next presenter.
Thank you, Wendy. So it's my pleasure to introduce the Low Back Pain Consortium, Quebec Low Back Pain Consortium. Ilya will be giving a presentation today. So the consortium is actually celebrating their 10-year anniversary this year. It's an initiative of the Quebec Pain Research Network. I am a member of the Low Back Pain Consortium, and really the goal is to assess possible risk factors that can help understanding why people with low back pain develop, start from an acute condition to more of a chronic condition. So we're interested in looking at biomarkers, genetics as well. And really it's a multidisciplinary group that includes 7 universities in Quebec: Concordia, McGill, Université de Québec en Abitibi-Témiscamingue, Université Laval, Sherbrooke, Université de Montréal, et Université de Québec à Trois-Rivières. So the group has worked on adapting questionnaires for low back pain people in Quebec and in Canada. And so far, they're also running studies where patients with low back pain fill questionnaires, and they were able to recruit over 5,600 individuals. So I will not say any more, and I will let Ilya continue with our presentation. Thank you, Ilya.
Thank you so much. Let me just share my screen. All right. Hi, everyone. Good morning. Thank you, Dr. Fortin, for the introduction, and Perform team that kindly agreed to give us a couple of minutes to present the Quebec Back Pain Consortium. So as Dr. Fortin mentioned, it was initially an initiative of the QPRN, the Quebec Pain Research Network. And right now it's a platform in collaboration with the Rehabilitation Research Network, the Report. All right. So the Quebec Back Pain Consortium is a multidisciplinary team of more than 20 researchers from the 7 big universities of Quebec, graduate students, policy makers, clinical experts from different disciplines such as psychology, epidemiology, genetics, epigenetics, physiotherapy, and orthopedic surgery. And we're also working in collaboration with our patient partner, Laurent Dupuis, who's been very helpful since the beginning of the study. And so the consortium objective is really to study the risk factors associated to the transition from acute low back pain to chronic low back pain, and really using a biopsychosocial approach. And so we're interested in knowing why certain people will develop chronic pain after injury, and why other people it will just resolve over time. So to do this, we're studying the biological, psychological, and social factors involved in this transition. So our team identified 3 main priorities. The first one is to evaluate the neurological, biomechanic, and genetic factors that may be involved in the persistence of low back pain. Second will be to identify relevant and useful biomarkers for clinicians, and then to develop individualized treatment. And these priorities are related to the Quebec Chronic Pain Management Action Plan introduced last November 2021 by our Quebec Minister of Health and Social Services. As we like to also facilitate access to the data that we collected in order to help you develop personalized treatments. So in this study, we collect self-reported online questionnaires at 5 time points, so at baseline, 3, 6, 12, and 24 months from adult participants that self-report as having low back pain. And the questionnaires are also available in English and in French. So once the participants complete the first questionnaire, we also collect their consent form to be contacted for additional satellite projects, such as participating in our biobanks satellite project and provide with a biological sample, such as saliva, stool, or blood samples at different time points. So researchers and partner organization can also gain access to the data that we collect or invite participants to participate in their satellite projects. So if we go a little bit back in time, so in 2017, our team published the Canadian adaptation of the NIH minimum data set for chronic low back pain. And you can see on the screen the different questionnaires that we collect in our study. So the questionnaire on low back pain, a component to assess the neuropathic pain of chronic pain, and health-related quality of life, and a self-reported comorbidity questionnaire, as well as the global impression of change. We also collect the RAMQ number and consent, so we can have access to their medical file and compare that with the data that we collect in our study. In 2020, we published our protocol paper, which is also registered in Clinical Trials website. And most recently, we just published a paper on the effects of 3 different acute low back pain definitions on patient inclusion and clinical profiles. And also very, very soon, we'll have another paper that was recently accepted for publication in Pain Reports. And it will present you the normative data of the chronic low back pain cohort. So the enrollment to this study is continuous and online based. It started in November 2018. And as mentioned, the participants are asked to complete a series of questionnaires at different time points. And you can see on the left the acute low back pain participants, and on your right is the total participants in the cohort, which were pretty much very, very close to 6,000 total participants. Of course, our main goal is to have about 1,000 acute low back pain participants at baseline, so we're still recruiting for now. Again, on the left, you'll see the acute low back pain participants retention, so 82% at 6 months and 81% at 12 months. And on your right, you will see the total retention of the whole cohort. Which is slightly lower because our focus is really to follow up acute low back pain participants over time. So again, participants are asked to complete the first baseline questionnaire, and we also collect consent at baseline so they can be contacted for additional satellite projects. And you can see on the screen that about 18% of people who already take part in the main study agreed to be enrolled in another satellite project, and then even 2 or 3 satellite projects. And eventually, we'll really like to integrate all the data together to get a bit more of an insight into those specific participants. So our infrastructures also allows to provide different services for you to help you optimize your research. So first, we can help you with recruiting participants for your projects. So we can do this by broadcasting an ad in our newsletter to more than 6,000 participants. And another option will be to put you directly in touch with the participants. Obviously, this is done through data use agreements. Also, we can also help you. You can also have access to the longitudinal chronic low back pain data through data use agreements. So you can see on the screen again the different questionnaires that we collect besides demographic questionnaires. And let me just, okay. We also have consulting services because since, well, Dr. Fortin mentions, we've been working on this project for about 10 years. So we learn a lot through the years, and we can definitely help you implement your research projects, starting with research ethics board procedures, marketing to recruit participants. So we work for a long time with the marketing team for several years, and we learn a lot from their expertise, and we tested many ways to recruit and participants, and collect data on our online data collection platform like RedCap or Trip. And since we have more than 6,000 participants, we rely on very powerful tracking and retention tools to follow up with them at different time points over time. And we can definitely help you implement those similar tools for your own projects. And finally, as we are a multidisciplinary research team, if you think your expertise can be useful for us, feel free to contact us, but also you can always benefit from different expertise within our team, and we're always open for collaborations. So again, feel free to contact us, whether maybe you have low back pain and you would like to participate in our online study, or you would like to facilitate your own research project by using some of the data for pilot studies or more. So because the results of this project will be really useful for us to guide management of pain and optimize care for people that live with low back pain. And finally, I'd just like to thank our partners, collaborators, sponsors, and of course, our participants who are making this research possible. All right. Thank you so much. And I don't know if we have a little bit of time for questions.
So we might have a couple minutes. If anyone has any questions, you can enter them in the Q&A feature. Okay, I guess it was a pretty clear presentation. So right now we're going to go to break. And then we have the student poster presentations that will begin at 10:45. It will be using a different link, so you can log off here and in 15 minutes go back to log into the student poster presentations if you like. Thank you everyone for joining, and thank you to our wonderful presenters. Have a good day.